This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to discuss Mirtazapine as a treatment for methamphetamine use disorder. Sonya, how are you doing tonight?
Doing really well. It's past geezer midnight, which we call it, which is 9 p.m., but we are still going strong, and I'm enjoying this recording session. How are you doing?
And you're recording right now, and what temperature is it over there? Like 100 degrees?
Yeah. Yes, I'm in my unair-conditioned attic recording studio where the sound is dampened by dirty laundry, and I'm feeling good.
Going strong. Love it. That's cool.
Oh my gosh. How about you? You feeling good?
I'm tired as always. I'm a parent.
I know. I'm a parent too, but yesterday was my youngest child's 18th birthday. So now I only have adult children in the house.
There you go.
So I don't have to do anything else, right? I'm done. I did my job.
Yeah. Well, I think it's like, isn't it like 18, mortgage, degree, and then you're done?
But then there's grandkids, you know. But no, we're never done. You're never done parenting. I look forward to parenting adults as well as having parented children.
It's probably different, right? You can have like real conversation with them. It's, you're not getting yelled at for giving them the wrong Fruit Loop colors or whatever.
Well, it's different, but it's also harder. They say like little kids, little problems, big kids, big problems. It's no longer about the Fruit Loops. It's about more serious issues.
Yeah, I can see that. So what do you got for addiction in the news this episode?
So I hate to keep like harshing on behavioral treatments for opioid use disorder, but there was yet another article I liked in JAMA Network Open about behavioral treatments as an adjunct to buprenorphine for treating opioid use disorder. Like, do you need these behavioral treatments? So this was a comparative effectiveness trial comparing CBT to peer recovery support for patients who are already on buprenorphine for opioid use disorder. And the outcome being this hard outcome of opioid abstinence. They found that neither intervention, neither CBT, cognitive behavioral therapy, nor peer recovery support made any difference in the outcome of opioid abstinence. And it just reinforces what we said before. The neurobiologic dysregulation of the brain from fentanyl is just too severe to be treated with therapy. It requires a pharmacologic solution. This was a pragmatic randomized controlled trial, so a lot of limitations, including patients not actually showing up for the many different therapy sessions, but I think it reflects what happens in practice. So then you get into the question of like, what does work mean when you're treating addiction, and what does work mean when you're evaluating a behavioral treatment? So the hard outcome of abstinence, outcomes like overdose, those ones have been shown that medication is pretty much the only effective tool. But you have these softer outcomes related to quality of life that a lot of people feel therapy is helpful with. The other question is, and this was shown in this study, and I see it in my practice, is the patients are unwilling to engage with therapy and with these behavioral treatments. So does that mean they don't work, or that they would work if people did them? Like we have a lovely peer recovery support counselor I work with, and just like some patients desperately need help and they won't call him back. So does that mean his intervention doesn't work because somehow people just won't do it? Or does it mean that it's the patient's fault and it would work if they did it? I feel the same way about diet and exercise. What do you think, John?
I mean, it's a tough thing to unpack, right?
Yeah.
I feel like you're just treating, I don't know. I think it can be helpful for people. I mean, the idea you blanket and make everyone do it, I mean, that's probably not the way to do it. But I certainly think that there's a lot going on in people's lives. Even if you took out, like let's say they're not even a substance use disorder patients, there's a lot going on in people's lives that they often do benefit from these services. I mean, how many times a week do you refer to counseling just in your general practice?
Oh, so many times.
How many times do you think that people actually go through with the counseling that you refer to?
Less than half make it to a single session, even though they've agreed in the moment to go for it.
Yeah, so I think there is something between like what I think a person identifies as that they need and that would help them, and then life gets in the way and they don't actually go, right? I think we all do that.
Oh, totally. Like Like, my hip was hurting me for, like, a year. It took me a
Mhm.
year of pain before I made it to the single physical therapy session, which was all I needed to make the pain go away, basically.
Yeah. So I think there's a role for people, especially when you have kind of thrown other things like, maybe not by itself, but in addition to, right? I think a lot of our patients also have like comorbid mood disorders. They have a lot of psychosocial, they had adverse childhood experiences. I feel like that group does benefit from involvement when they're ready.
Right.
But it's like
Well
going to the gym, right? You gotta want these services for them to work. So if you already have in your mind that this is not gonna work and you're not gonna like put the work in or you're not gonna like, kind of engage with it, you're not gonna get a good outcome. It's like that guy at the gym walking on the treadmill drinking a milkshake or drinking the 800-calorie smoothie from the smoothie place. Like they're not getting anything out of that. It's because 'cause they're not engaged.
Yeah, it's just hard. I Our recovery support and our therapy services are super helpful for the people who do choose to engage with them. But when you get into questions of resource allocation, like how are we gonna spend our money, say, it's like we gotta focus on things that are effective, and figure out how we determine that. Um, so I don't know, I just thought it was an interesting paper.
I also feel like effectiveness sometimes playing devil's advocate. I feel like a lot of our trials though, I think they're like no like there's a statistically difference in opioid use or overdose, but they're I mean what are the trial durations typically, right? They're
Mhm,
not we don't have decades long trials. I often feel that people that feel that they recover with these types of methods, they often feel like they often kind of talk about more sustained when it does work. I feel like I
mhm.
have tons of people that, medication by itself works great for 18 months. I mean, would the trial be over by then? What about 24 months, 36 months? I mean, what percentage of all patients you treat do you have that are like, plus 5 years? I have some, but it's not the majority, right?
Right,
I don't know. I think that's a big bias too, is the duration of some of our trials.
right. Well, right, they cut off before that natural drop off out of treatment.
Yeah.
So, well, interesting, very interesting. But yeah, yet another paper about, behavioral treatments. And I mean, the one takeaway I think we can all agree on is that behavioral treatments should not be mandated as a prerequisite for receiving medication.
Yep.
And medication should always be offered. Many patients prefer not to take medication, which is fine. But it should always be an option. It should never be sort of withheld, from patients.
I feel like one day you're gonna go to your car in the parking lot, and there's gonna be a bunch of people like with Birkenstocks. They're like counselors and psychologists, and they're just gonna be waiting for you with
I
you bashing on this
know.
group.
I'm so sorry. I love the therapist, and I love working with therapists. I love working with recovery support, and the patients who are engaged just, like, love it. It works for the people it really works for, but that's not the same as saying that it will work for everybody, and everybody has to do it. And if you have limited resources and you're like a health system or a county or a state, those resources gotta go to what's the most effective treatment. How about you, John? Anything, you wanna share with our audience?
Yeah, I have this article from NBC News, and it's about Zen. So it's titled "Are Zen pouches safer than smoking?" The FDA weighs in, and so a little update. Zens are these little nicotine pouches that people put in their mouth. It's marketed as a safer alternative to smoking. Well, the FDA has just authorized Swedish Match USA, which is part of Philip Morris International, to market 20 of the Zyn nicotine pouch products sold as a lower risk alternative to cigarettes. So basically allowing marketing in that regard. So as kind of a lower risk tobacco option. The authorization allows Zyn to state that these products reduce exposure to the risks associated with smoking, like mouth cancer, lung cancer, heart disease, stroke, COPD, things that we associate with combustible cigarettes. The FDA decision applies to like several different formulations, a 3 and a 6 milligram pouch, multiple different flavors like cool mint, citrus, coffee, cinnamon. I don't know if any of those sound appealing, to be honest with you. They don't contain tobacco or involve any combustion. So I think it's interesting take. One kind of counter argument for this is that, these alternative nicotine consumption methods, whether it's a vape or these nicotine pouches, they really feel like that there's some of this is also being marketed towards kind of a younger non-smoking population. So kind of our 18 and minus kind of young adults. And they actually did a study that showed that from the 2025 National Youth Tobacco Survey, found that 1.7% of middle school and high school students reported using nicotine pouches, which that's kind of, I mean, high school students, I guess 2%, but I feel like 1.7%, like middle school, that's pretty surprising to me. It's like my kid.
Well, I mean, I think though they're discreet, and if you have them in the house, like your parents buy them, you know, not so hard to take a few.
Yeah, the FDA has required Swedish Match USA to conduct a 5-year post-market analysis to kind of like assess the risks and how consumers perceive this new marketing. So there is going to be some follow-up, but I think it's interesting. It's really kind of marketing as a true harm reduction here. I'm not sure. Do you recommend like these nicotine pouches or Zins particularly? Not that Zins paying us off, or I have a T-shirt or anything, but do you recommend these for smoking cessation?
Yeah, I recommend nicotine substitution as one of multiple interventions I recommend for people. And I tell them to try something that's different. I don't necessarily recommend vaping unless they have a real strong quit attempt going because I feel like people just end up smoking and vaping. But I do recommend nicotine substitution, gum, patches, gum, lozenges. If they want to use pouches, that's fine. But I really try to keep it in the context of a quit attempt. I don't want you to be using the pouches for the rest of your life either, but it's got to be better than cigarettes. So yeah, I do recommend it. I try to let people choose something that works for them. But I worry a little bit, these additives, these flavors, and the cute packaging and the tastes, they all lead to it being a habit forming product in and of itself. I mean, I think that's the thing with the gum. It's like slow onset. It doesn't have a very exciting flavor. It doesn't come in a very exciting package. It's not designed to make you addicted to it, whereas Zyn is. And it's interesting that Philip Morris is getting into the smoking cessation business also, you know? It's like, thanks, Philip Morris, for killing so many people worldwide and now also making money off the addiction that you, caused.
Yeah, it's interesting. I think a similar approach, right? Like, so certainly smoking cessation altogether is best, but I do have people that they're just not ready for it, and I often recommend these kind of harm reductions. I prefer like a nicotine pouch over a vape, but I think even a vape over cigarettes seems like it's harm reduction to some extent. So I'm not recommending anyone to pick those habits up. And you know, I think people get tired of hearing me say it's like it's not like you're going for a run or eating an apple, but it's better.
Right, it can't be worse. That's what I tell people. I'm like, it truly can't be worse than cigarettes. So,
This is true.
switch over. Go for it if you want to.
All right. So tell us about the study.
So, this is an article that we presented in our live journal club just this past month. And it's something I've been really interested in for a while. This is an article titled Mirtazapine for Methamphetamine Use Disorder, a randomized clinical trial, and it was published in JAMA Psychiatry in June of this year, 2026. So, a little bit of background I just want to share with our readers before we really kick it up. The first is that, as we know, drug use deaths and overdose deaths from fentanyl are going down. Thank you, everybody who's working in addiction medicine to make this happen. And overdose deaths from stimulants like methamphetamine are the same. They are also going down, which is really great, but they're still pretty high. They still account for a significant number of overdose deaths in our country. So it's not nothing. These are not insignificant problems here. The next thing I wanted to share in terms of background is that the number of people who are dying from methamphetamine overdose, which is about 26,000 per year, is in line with other problems we see in primary care. But just think of the difference in resources. So we have about 26,000 methamphetamine overdose deaths in the US. We have about 42,000 breast cancer deaths. So, more than methamphetamine, but same order of magnitude. We have about 6,000 influenza deaths, up to 52,000 in a bad year. So either more or less than methamphetamine. We have about 44,000 motor vehicle deaths. But just think, John, of the difference in resources between these types of illnesses. Think how much money and effort we are putting into flu shots, into mammograms, they are literally, my pay is like literally reduced from this past year because only 76% of my eligible patients got mammograms. I still think 76% is pretty good, but it is not good enough. And I really want everybody to get mammograms. And our health system is, ties some of my salary to that quality metric. But what about my patients with methamphetamine use disorder? Like, where's the quality metric attached to that? What percent of patients are receiving evidence-based care or dying of methamphetamine overdose? So there's a huge difference in resources in treating methamphetamine use disorder compared to other things in primary care. The other problem with methamphetamine use disorder is that the current standard of care is behavioral, especially a program called contingency management. It leads to a 50% reduction in mortality. It is just not available in many places. There's no FDA-approved medication for methamphetamine use disorder. And the most effective medication is bupropion plus a long-acting injectable naltrexone, which leads to a sort of modest 27% reduction in meth positive UDSs. So like there's these therapy techniques which no one offers because somehow they're not financially viable. And then there's medications that don't really work. So there is a huge need for better treatments for methamphetamine use disorder. The other problem is that the majority of methamphetamine overdose deaths also involve opioids. A lot of patients are addicted to both. And once patients come into treatment for opioid use disorder with buprenorphine or methadone, they're no longer able to take naltrexone, which is the most effective treatment. So suddenly that's off the table. So there's a huge need for treatments for methamphetamine use disorder for patients taking opioids. So with that said as background, let's talk about mirtazapine, which this study looked at. So before I get into that, John, do you feel like you have luck treating patients with methamphetamine use? What do you normally do?
Nah, it's really difficult. I feel like it's hard because I don't have access to contingency management. I end up, there is some data regarding kind of combination bupropion and IM naltrexone. Although, most of my patients also have an opioid use disorder. So, and they're on some sort of agonist or partial agonist. That's difficult. I feel like end up with a bunch of off-label options, like good old topiramate. I feel like I use mirtazapine sometimes. It's just kind of very difficult.
Right, right. The wonderful world of off-label treatments for substance use disorder. So here's mirtazapine coming along, not a new medication. It's been shown in the past to treat methamphetamine use disorder. There's some promise, but the studies have been relatively small and they've mostly been in men. So there's very little data in women. Mirtazapine is a TCA, a tricyclic antidepressant, and it inhibits dopamine function via its affinity for the serotonin receptors, the 2A, the 2C, and the 3 receptors, which may be why it reduces methamphetamine's rewarding effects and ameliorates that dopaminergic dysregulation you get with excessive methamphetamine use. It also blocks these alpha 2 adrenergic receptors, which are very dysregulated in methamphetamine addiction, and it is a histamine antagonist. So it both helps with sleep, it benefits insomnia, it benefits anxiety. So mirtazapine hits a lot of different receptors. That's what we would call a little bit of a dirty drug, affecting lots of different receptors in the brain. The other thing they looked at in this study, and they looked at in previous studies, you would think maybe mirtazapine's acting as a sleeping pill and an antidepressant. And if you're less tired and less depressed, you'll have better luck quitting methamphetamine. But the reduction in methamphetamine use that it offers seems to be independent from its effect on depression and insomnia. It reduces methamphetamine use even in the absence of other effects. So it's a kind of a separate mechanism of action that's not fully understood. So let's look at the clinical question here. This was a phase 3 parallel group, double-blind, placebo-controlled, randomized, all the adjectives, clinical trial, 339 people, and they compared mirtazapine, 30 milligrams a day, to placebo with the goal of reducing days of methamphetamine use over 12 weeks. So a hard outcome, reduced methamphetamine use, 3-month duration, and it was a double-blind placebo-controlled trial. They included adults age 18 to 65 who had moderate or severe methamphetamine use disorder over the past year. And you had to be using methamphetamine currently. You had to use it at least twice a week in the 4 weeks prior to enrollment in the study and have a positive drug screen result for amphetamines. They excluded people who were taking other antidepressants, who had attempted suicide in the past, who were pregnant, of course, lactating, who were critically ill, like needing acute medical inpatient care, ICU care, or for some other reason couldn't take mirtazapine. This was done in Australia in 6 different outpatient government-run alcohol and substance use disorder clinics, done in 2025, so very recent collection of data. In general, people were middle-aged. Mean age was 42, 37% were women, 53% were unemployed, and on average, they had been using methamphetamine for 24 of the previous 28 days prior to enrollment in the study, so almost all daily users. And they had been using methamphetamine for a mean duration of 21 years. So these are entrenched users, 21 years on average of methamphetamine use, almost daily use. So that's who is in this study. And they were either given mirtazapine 30 milligrams a day for 12 weeks or a matching placebo. If they wanted to stop it, if they had side effects, they were allowed to reduce the dose to 15 milligrams and continue in the study if they wanted to, just to facilitate trial retention. After the 12 weeks, they were given 15 milligrams for an additional 4 weeks and then stopped altogether. And the primary outcome was change in days of methamphetamine use in the end of the study compared to the beginning of the study. They also looked at some secondary outcomes like changes in depression, insomnia, HIV risk behavior, quality of life, and then methamphetamine negative. They did oral fluid samples. They also looked at suicide risk and other substance use. So, John, what do you think of the clinical question? Do you like the setup of this trial?
Yeah, I think it seems kind of really reasonable, very real world in many regards. Kind of reflects, I think, what I could potentially see in my clinic. How about you?
Yeah, I mean, it's a classic question, classic setup, placebo, randomized controlled trial. So, yeah, I think it was a pretty good setup. In terms of validity, it had a lot of strengths. It had a large sample size. It was randomized, double-blinded, placebo-controlled. They really did a good job making 2 similar groups at the start of the trial, and the setup was pretty good. They received equal interventions other than the study medication. They also had, good retention for a trial of substance use disorder. That week 12 assessment was available for 86% of patients, and, they also did an interesting calculation I liked where they asked patients if they had used methamphetamine, and then they compared that to the objective measures of methamphetamine use, like this oral fluid sample, and they compared the subjective and objective measures, and they found that if you compared self-reported meth use to the gold standard of positive methamphetamine positive oral fluid, the sensitivity was 89% and specificity was 83% for the self-reported data. So pretty good sensitivity and specificity for self-reported data. So that was just a side fact I thought was nice in this study. Outcome of number of days of methamphetamine use was clinically meaningful indicator of meth use. They reported adverse events because this is theoretically it would be a new indication. They did an intention to treat analysis and several pre-specified subgroup analyses, and they included women. As I said, previous trials have focused on men who have sex with men. Often methamphetamine has been used in the past in the context of sexual activity. So that's a population that had been focused on. And I don't think funding was going to cause bias. It was funded by the Australian government and the University of New South Wales. So a lot of strengths, a few limitations. There was low adherence to the study medication. So 50%, 52% overall of the medication was taken in this study. There was a high dropout rate due to adverse events. So 23% stopped the mirtazapine because they had an adverse event, compared to only 15% in the placebo group. Follow-up was 12 weeks, which is kind of short given that the average duration of methamphetamine use in this population was 21 years. These are just really entrenched methamphetamine users. And so it's a population that might struggle to be successful with any intervention, especially one that's known not to be very strong, like mirtazapine. So it's just working with a population that's very hard to treat. So that's the setup, but I think it was a valid trial. John, do you think it was a valid trial?
Yeah, I think so, definitely.
All right, so let's talk about the results. So remember, we're just comparing mirtazapine to placebo. The mean reduction in days of methamphetamine use from baseline to week 12 was greater in the mirtazapine group. So they reduced their methamphetamine use by an average of 7 days out of the 28. whereas the placebo group reduced its meth use by an average of 4.8 days out of the 28. So it's a mean difference of 2.2 days, which is an 8% reduction in use. So mirtazapine led to an 8% reduction in use. There were a lot of adverse effects leading to medication discontinuation. The two biggest ones were drowsiness and increased appetite and weight gain. So we all know mirtazapine causes drowsiness. It's actually used primarily in primary care as a sleeping pill for the elderly because it's relatively safe. And then it increases appetite and can cause pretty significant weight gain. So those were the two side effects that were different from placebo. And as I said, the mirtazapine group had a pretty high dropout rate compared to placebo. So will these results help me in patient care? To summarize, mirtazapine slightly reduced methamphetamine use in adults with methamphetamine use disorder with no unexpected or serious safety concerns. So it worked okay. The patients in the study were similar to mine. Treatment is feasible. I know how to prescribe mirtazapine. I already use it quite a lot. There was no unexpected safety concern. So I'll just quote the author. They said the clinical significance of these findings in identifying a safe and cheap generic medicine that can be prescribed to help people reduce use, that's the clinical significance. It has a well-established safety profile. It can be easily and safely prescribed in outpatient setting without a lot of clinical oversight. And the other treatments for methamphetamine use disorder, i.e. stimulants or long-acting opioid antagonists like injectable naltrexone, a lot of people are not comfortable with that in general primary care. And they require pretty close supervision to manage, potential risks and side effects. So this is a treatment that's available to everybody. And so it does have a place, but it's disappointing that it wasn't more effective. So, John, do you think this article will change your practice?
I mean, I still think we're still looking for something in this domain, right? I feel like I'm glad that we have something I can trial or offer off-label if truly someone's struggling. It's a safe medicine. I mean, we use it all the time. I just feel kind of underwhelmed by the clinically significant results. Like, this seems clinically significant. I don't know how much, or statistically significant. I don't know how clinically significant this change is.
Like a difference of 2.2 days out of 28 compared to placebo. And someone who's used methamphetamine for 21 years, instead of 24 days a month, you use it 22 days a month. Like, has that really changed your life?
Yeah, I mean, like, again, statistically significant. I'm not sure clinically significant. I think it's nice to have something to offer.
Well, I think that's really what it is. It's considered unethical to knowingly offer your patients a placebo. So this does quote unquote work. So it is not a placebo, but
vitamin D.
Vitamin B12. Oh no.
Vitamin D and B12 are out.
But it does work. And a lot of times patients just want something to try. They're desperate for help. They really want to try something. And if you can give them something with a hope that maybe this will help, that's good. And also, with the high dropout rate, I do feel like if people sort of stuck with it, maybe it would be a little more effective. So you could also tell people, like, anticipate the side effects, stick with it even though you get these side effects. Maybe it'll help even more. I just tell people, sort of like quitting smoking, this medicine's not going to force you to quit, but it's just going to make it easier when you're trying to quit.
I also think, looking at it, like, this was kind of like most of the inclusion criteria here was like moderate to severe methamphetamine use disorder. You have to hit a lot of bullet points on that diagnostic criteria for that. I think if we're being honest, I often see this as part of like a poly substance use. And I bet you, to be honest with you, the methamphetamine does not seem to do as much damage in the life. So I think for someone with like an opioid use disorder that also meets criteria for like a mild to moderate, this might be a good option, right?
Yeah. Well, it definitely makes me think of using mirtazapine as like first line treatment for insomnia with opioid use disorder. People just don't like the weight gain, which, and I wouldn't like that either.
No, I don't want that. Although people love their Seroquel, right? I mean, they love that. And that's a weight gainer, right? People love that.
People do love Seroquel. I don't have anything else to say about that. All right, take us home.
Well, that was great. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email our Facebook group. The links are on the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCare is produced by Dr. Patrick Beeman and Ars Lanca Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.